Okay, guys, we're going to get back to the algorithm here. So if you look back to that blue box about halfway down this algorithm, along with persistent tachyarrhythmic causing. So basically, this is going to be now they're stable. The answer is no to all those questions. In other words, they're not hypotensive. So we get a little bit more time to understand and treat this patient. So we're going to follow the no down to the wide QRS. So is it a wide QRS, yes or no? Now, wide QRSs are deceiving and they look weird, so that's why this is a special consideration. Because you see here, it's just kind of wide and ugly looking. It's not exactly comfortable. Another wide QRS could be something like this. Now, this is exactly why this diverts off here, because this could be something like VTAC, or a very wide QRS SVT. You don't know. So the algorithm allows for this, that you don't know. So let's move to the right in the yes option. And it just gives you more information, more things to do. Make sure you have IV access. Make sure you have a 12-lead EKG. Hopefully you have all that before this. Consider adenosine only if it's regular and monomorphic, which is the two things I just showed you. Both of those were regular and monomorphic. See, there's no different complexes. It's all pretty similar. Now, if it's irregular and not monomorphic, polymorphic, could be something like this, and that's a whole nother ball of wax. We're not going to talk about that too much, but basically, if you see something that is not completely regular and looks like this, then you don't want to worry about adenosine, because probably there's more things going on than adenosine can fix or diagnose. So once again, we are in the wide QRS, that right-hand side column. That's when they want to talk about doing an antiarrhythmic infusion. And for us, the gold standard is amiodarone. The dosing for amiodarone is 150 milligrams IV mini bag infusion over 10 minutes. If they're alive, in other words, if they have a pulse, you do not push amiodarone, only if they're dead. Now, if they're dead, the dose is 300 milligrams IV push. That being said, we have an alive patient for now. So you want to do 150 milligrams in a mini bag over 10 minutes. And that's available in our Pyxis. And the next step down, it says consider expert consultation. Because really what you could have is VTAC with a pulse, which is possible. Not VFib, just VTAC. Or torsades with a pulse. You just don't know. So getting that antiarrhythmic on board and then getting a little extra help is a good call. A word about amiodarone. Typically after that 150 milligram 10-minute infusion, you will hang a larger bag at 1 milligram a minute for 6 hours. And then depending on the dosing, it'll convert to 0.5 milligrams for 18 hours. Or sometimes if they can't take PO, they might keep them at 1 milligram. It all depends on that second end of the order. But the immediate first dose is the 150 over 10 minutes. Okay, we're going to bump back to the wide QRS, yes or no. And if it is no, if it is still a narrow QRS, this is the bottom of the algorithm. In other words, the patient is the most stable. Adenosine is a chemical agent that can be used to cardiovert a tachycardia. However, most of the time, it's really given to just diagnose what that rhythm is. And the way it works is slowing down that heart rate, almost rebooting it down to 0. Sometimes you'll see 0, sometimes you'll just see a slowing where that SVT all of a sudden shows itself as AFib. And by knowing what the rhythm is, or at least the underlying rhythm is, without the SVT component, you can help treat it and take care of the patient more effectively. Adenosine is dosed, the first dose is typically 6 milligrams, and then a following dose of 12. Now, if they have central line access, you're going to be giving most likely 3, and then a second dose of 6. One of the most important things about adenosine is that it is incredibly short-acting, or short half-life rather. So you're going to need to follow the push of the medicine, the adenosine itself, by a large 20 cc flush immediately afterwards. And that's when you'll see some folks using the stopcock with the, syringe attached to the various ports in the stopcock, so you don't have to worry about switching to the hub with different syringes. However you choose to do it, just be ready to give that fast flush afterwards. That's the most important part of giving the adenosine. Another thing to do is to warn the patient. Let them know that it's going to feel funny. They might feel like they're falling, they're on a roller coaster, because essentially you're kind of stopping their heart, if it works properly, for a couple seconds until that heart rhythm reboots. So, and again, take care of the patient, warn them. Now, on the monitor, you're going to have a continuous report available centrally of what's going on with the patient, but this is when you've already hooked the patient up to the Zoll. You can hit that record button on the Zoll and you'll get a nice little paper printout of the adenosine push. Okay, so if you have any more questions about adenosine, there's dosing is on the bottom of the page, and we could just talk about it another time too. I'm going to pause the video here and then we'll boot back up to doing a cardioversion with the Zoll. Okay, that about does it for the algorithm. If you have any questions, please don't hesitate to ask one of us. And speaking of questions, I have a few for you. Once again, these are in the folder if you need them other than me reading them to you, and get them back to us so we can give you credit. Okay, first up, I want to know about adenosine. What is the dosing for adenosine for peripheral and central access? Next up, once you've cardioverted, is the Zoll ready to cardiovert again? I'll ask that again. Once you cardiovert, is the Zoll ready to cardiovert again right afterwards? Next question is, tell me an example of a vagal maneuver. And then last, I'd like to know what is the standard antiarrhythmic that we use in the hospital. And once again, I'm looking for the standard antiarrhythmic used in the hospital and what the initial dose is. All right, guys, thanks.